So today we're looking at some math that honestly kind of blew my mind. We look at the math that proves a nurse can run a primary care clinic for roughly like $150,000 less a year than a traditional doctor.
Yeah, which is, I mean, it's a massive number.
Right. And we're also going to get into the sort of hidden, almost warfare level legal stuff they have to go through to actually pull that off.
It really is an incredible structural shift because we're looking at this fundamental arbitrage opportunity in the American healthcare system, and it is entirely driven by this quiet, kind of overlooked rise of nurse practitioner practice ownership.
Yeah, exactly. And that is the core of our deep dive today. We were exploring the reality of what happens when a nurse practitioner, an NP, decides to, stop working for a giant hospital network or a doctor's private practice and just build a medical business completely from scratch.
From the ground up.
Right. So we've pulled together extensive data on the economics of this, and it's all anchored by the foundational business and legal strategies laid out in Carolyn Buppert's work, specifically her textbook chapter on NP practice ownership.
Yeah, it's a fantastic source.
It really is. But what we're actually talking about here is this crazy collision between clinical care, just raw economics, and honestly, some of the most complex employment law in the country.
Oh, absolutely. Because the old model of the healthcare business is just incredibly entrenched. Like for nearly a century, the public assumption has been totally binary.
Right. You have the doctor who owns the practice, and then everyone else is just an employee.
Exactly. But that landscape has completely fractured over the last 15 years or so. You have NPs opening, travel medicine clinics, urgent care centers, pediatric primary care, specialized wound care facilities. They are the captains of these ships now.
Yeah, they're the boss.
Right. But to actually get the doors open, they have to navigate this regulatory environment that was explicitly built for an entirely different type of provider.
Right. The whole system is basically architected around the MD. So when an NP enters that space as an owner, the friction is just immediate. So if you are, say, an NP dreaming of striking out on your own, or maybe you're a patient wondering why your neighborhood clinic looks and operates a bit differently these days, or, even if you're just someone fascinated by the sheer mechanics of small business survival, this deep dive is going to completely rewire how you look at the medical industry.
I really think it will. And to understand the mechanics of the business, we first have to, establish the motivation.
Right. The why.
Yeah, the why. Because the barriers to entry here are so steep and the liability is just immense that we have to ask why someone would willingly subject themselves to this amount of stress. And the prevailing answer across the board is clinical autonomy.
Let's drill into that for a second. Because autonomy is one of those buzzwords, right, that gets thrown around a lot in the business world. Usually it just means, like, you don't have a boss literally looking over your shoulder. But in a clinical setting, autonomy dictates the actual flow of healthcare. It's the difference between a practitioner deciding, hey, this complex patient needs a 30-minute consultation, versus a corporate hospital administrator mandating that every single patient must be cycled through that exam room in exactly 7 minutes to just maximize billing codes.
Exactly. It is entirely about controlling the environment of care. An employed MP is often on this relentless corporate treadmill. They don't choose the patient load, they don't choose the referral networks, and crucially, they do not capture the financial value of their own efficiency.
Wait, unpack that a bit. What do you mean by capturing the financial value?
Well, think about it. If an employed NP streamlines a process and manages to see, 5 more patients a day, the hospital's profit margin expands. But the MP's salary...
It stays exactly the same.
Right, it remains static. But ownership completely flips that dynamic. If they build a highly efficient practice, they actually keep the profits. They keep the equity.
Which makes sense.
Yeah.
And there's also a massive downstream benefit to the patient here, right? Like you, the listener, you actually benefit from this. Because the nursing model is historically very holistic. It's really heavy on patient education, preventative counseling, really managing the whole person.
Yes, and then the medical side brings the diagnostic and treatment architecture.
Right. So when an MP runs the clinic, the patient often gets this really unique synthesis of these two models. And practically speaking, it usually translates into significantly more face-to-face time.
It does, and it also addresses a huge issue with access. In a lot of rural areas or even underserved urban areas, a traditional physician-owned practice simply cannot mathematically survive on the available payer mix, or frankly, there just aren't enough physicians to meet the demand.
Because they're all clustering around big hospitals or wealthier suburbs.
Exactly. So NP-owned clinics fill this exact vacuum. They provide really high-quality first-level care without the patient having to, wait 3 weeks for an appointment or default to a vastly more expensive emergency room visit for something basic.
Right. Which clogs up the ER anyway. But the trade-off for all that wonderful autonomy is, honestly, this absolute terrifying level of liability. I mean, if you own the practice, you aren't just the clinician anymore. You're the facilities manager, you're the HR department, and you're the legal compliance officer.
Oh, yeah. You wear every single hat.
It's like the classic American dream of opening a restaurant. Right. Everyone wants to be the executive chef and the boss. But in this case, the restaurant requires you to navigate Medicare, deal with hospital ER referrals, and, well, we'll get to this, potentially pay your competitor just for the legal right to open your doors.
Yeah.
And if you catch the flu, there is no hospital staffing pool to call for a substitute.
No, you're completely on your own.
Right. Either find coverage yourself or the clinic shuts down for the day. Which means revenue instantly drops to zero, but your fixed costs, like your rent and your malpractice insurance, they just keep right on accruing.
And that operational vulnerability, that's just scratching the surface. The deeper agony really lies in the structural barriers. Just getting admitted to commercial insurance provider panels is a notoriously hostile process for new independent providers.
Because the insurance companies don't want to pay new people.
Well, they're just incredibly slow. There's this massive lag time, often many, many months, between actually seeing a patient and getting paid for that visit while you fight this bureaucracy.
Wow, so you're just floating the costs for months.
Exactly. And then, on top of that, you have state-by-state scope of practice laws. In certain jurisdictions, an NP might own an incredibly thriving primary care clinic, but they lack the legal authority to sign the paperwork to, say, admit their own patient to a nursing home, or to authorize home health or hospice services.
That seems like an intentional bottleneck. I mean, think about that. The NP manages this patient's care perfectly for 10 years. But the moment the patient needs hospice, the NP just hits a legal wall and has to hand them over to a physician who has literally never met them. It's jarring.
It is incredibly jarring. It's basically a legacy artifact of how medical legislation was drafted back in the mid-20th century. And it fundamentally shapes how these NPs have to build their business plans. Because the NP cannot rely on a frictionless integration with the wider healthcare system, their initial economic calculus has to be flawlessly calibrated.
Which brings us right into the math. And I love this part, because let's look at the actual ledger. This is where the theory of autonomy totally collides with the brutal reality of capitalism. The data we pulled outlines the baseline costs of running a primary care practice, and the sheer volume required to stay afloat is staggering.
It really is.
So let's establish the baseline using a traditional solo physician practice. What are we looking at?
Okay, so the fixed and variable overhead for a solo primary care practice is immense. We are looking at a baseline of roughly $200,000 to $300,000 a year just to keep the lights on. And that is completely excluding the provider's compensation.
Wait, $300,000 before the doctor even pays themselves a dime? Because we are just talking about, like, a lease on a commercial space and a receptionist salary. A medical clinic requires an entirely separate, crazy tier of infrastructure. You have specialized hazardous waste disposal contracts.
Oh yeah, the red biohazard bags.
Right. You have to pay federal registration fees just to have a basic laboratory in the office.
Yeah.
You have answering services for after-hours triage. You have application fees for hospital admitting privileges and incredible expensive electronic health record EHR software licenses. It adds up fast.
It really does. So let's run a standardized model to see how this translates to daily operations. Let's assume our hypothetical MD practice has that $300,000 in annual overhead. And let's say the physician is targeting a competitive salary of, say, $250,000.
Okay, so $300K plus $250K.
Right. That means the practice must generate $550,000 a year in pure collected revenue. And I want to stress, not billed revenue. Because insurance companies routinely deny or downcount claims. We're talking about actual cash in the bank.
Okay, $550,000 in collected cash. If we assume they average, $100 per patient visit, that requires 5,500 patient visits every single year.
Exactly, 5,500 visits. Now let's compare that exact same physical footprint to a nurse practitioner practice. The baseline overhead, the rent, the biohazard disposal, the front desk staff that remains largely identical, the physical infrastructure costs what it costs.
Right. The landlord doesn't care if you're an MD or an MP.
Exactly. But there are two massive deviations on the NP's balance sheet.
Okay, the first one is actually a huge advantage, right? Malpractice insurance. The data shows that an NP's malpractice premium is a fraction of a physician's. We are talking maybe $3,000 to $5,000 a year, whereas an MD might be paying tens of thousands depending on their specialty and their location.
It is a massive cost reduction. However, in many states, that savings is immediately neutralized by a uniquely frustrating regulatory cost, which is the collaborative agreement fee.
Ah, here we go.
Yeah. In jurisdictions where NPs do not have full independent practice authority, or if they wish to bill certain government programs like Medicare, they are legally required to maintain a written collaborative agreement with a physician.
And I'm guessing the physicians don't just sign that for free.
Definitely not. Physicians generally charge a substantial fee for this service. So structurally, the NP is often forced to pay a competitor just for the legal right to open their doors.
That is wild to me. It's basically like opening an independent coffee shop, but the city mandates that you have to pay a retainer to the manager of the Starbucks down the street just to oversee your menu.
That's a great analogy. It's exactly like that.
But even with that collaborator fee totally zeroing out the malpractice savings, the NP model still requires vastly less revenue to survive. Why is that?
Because of the compensation expectation. A highly experienced NP running a solo practice might target a salary of, say, $100,000 to $120,000, which is highly competitive for the profession, though obviously significantly less than the physician's $250,000 target. So if we take that same $300,000 in overhead, adjust it slightly for the specific nuances of an NP operation, and add that $100,000 salary, the total revenue target drops to roughly $385,000.
Okay, so let's pause and look at that.
Yeah.
The physician needs $550,000. The NP needs $385,000.
Yeah.
That is the $150,000 efficiency gap I mentioned at the very start of the show. So how does the NP hit that $385,000 mark?
Well, let's assume the NP is reimbursed at a slightly lower average rate from the insurance company, say $85 per visit instead of $100. To hit $385,000, the NP needs to conduct roughly 4,500 patient visits annually.
Okay.
And if you break that down by a standard working year, it equates to seeing 19 to 20 patients a day, 5 days a week, 47 weeks a year.
Wow. Okay, I have to push back here because doing the mental math on the logistics of this, it's daunting. 20 patients a day. That is a grueling, relentless treadmill. And remember, the NP is the clinician and the CEO. So between 9 a.m. and 5 p.m., they have to physically examine 20 people, diagnose them, write the prescriptions, chart all the encounters in the software, and then on their lunch break, they have to figure out why the payroll system crashed. Or call the biohazard company because the pickup was missed.
Yeah, pretty much.
That doesn't sound like autonomy at all. It just sounds like inventing a new way to exhaust yourself. Like, is this really autonomy, or is it just a fast track to severe burnout? Is the juice really worth the squeeze here?
It is a highly valid concern, and it is honestly the primary reason many private practices fail. The administrative burden just crushes the clinical workflow, but we have to look at the alternative reality.
Yeah.
An employed NP working in a massive hospital network is almost certainly being pressured to see 20 to 25 patients a day anyway. The workload already exists in the market.
Oh, wow. Okay, so the physical exhaustion is just a baseline reality of modern primary care, regardless of where you work.
Precisely. The critical differentiator is agency. When you see 20 patients for a corporate hospital, the margin generated by your 18th, 19th, and 20th patient of the day goes to a shareholder or to an executive bonus pool.
Right.
But when you see 20 patients in your own clinic, that margin pays down your business loan. It builds your equity. It gives you the financial leverage to eventually hire a second provider and scale the business. It is literally the psychological difference between digging a ditch for someone else's foundation and digging the foundation for your own house.
That makes total sense. Put like that, it's a completely different mindset.
Yeah.
But because that math is so incredibly tight, I mean, you're relying on a high volume of just $85 visits, the structural foundation of the business has to be bulletproof.
Oh, absolutely.
Because if your overhead creeps up by like 10% or your patient volume drops by just 2 people a day, your entire profit margin just vaporizes.
Yeah.
Which means the NP has to make incredibly precise, flawless strategic decisions before they even sign a lease.
Which is why the pre-flight checklist for opening a clinic is so extensive in the source material. And it all starts with the most fundamental architectural decision: solo versus group practice.
Yeah, let's talk about that because I can totally see the allure of going solo. It's absolute purity of vision, right?
Mhm.
You don't have to compromise on the clinic's culture. You don't have to support the overhead of a partner who, maybe might not work as hard as you do. And frankly, you can never be fired from your own solo enterprise.
That's the dream, sure. But solo practice is an island, and the lack of economies of scale is brutal. Think about if you buy a $10,000 piece of diagnostic equipment, a solo practitioner bears 100% of that cost. In a group practice with 3 providers, that cost is distributed.
Right, divided by 3.
Exactly. The same goes for the front desk staff, the billing manager, and the EHR chauffeur. Furthermore, a group practice offers shared call coverage. If you are solo, you are on call every single weekend, every holiday, forever. A group allows for basic human rest.
Yeah, that social support and shared risk is huge. Now, you mentioned EHR, software electronic health records. The data is incredibly firm on this, right? Like attempting to open a clinic with paper charts to save money early on, with the intention of maybe digitizing later. That is basically a death sentence for a practice's efficiency.
It is a catastrophic logistical error. Do not do it. The data architecture of modern medicine is entirely digital. If you start on paper, not only are you completely isolating yourself from health information exchanges and lab integration, but the eventual transition to digital will require you to effectively shut down your clinic for weeks just to migrate the data.
Which means zero revenue for weeks.
Exactly. The cost of an EHR must be absorbed as a day-one foundational expense. It's non-negotiable.
Right. And the physical footprint is just as strategic, isn't it? Like location strategy. You can't just hunt for the absolute cheapest commercial square footage and call it a day.
No, not at all.
If your target demographic relies heavily on Medicaid and therefore public transit, placing your clinic 2 miles away from the nearest bus line means your patient panel simply cannot physically reach you.
Right.
Or if you are targeting a suburban working professional demographic, you need ample free parking, or they will literally just drive to the urgent care down the street. It is pure retail strategy applied to medicine.
And part of that strategy is proving your value immediately because the market is saturated. An independent NP has to objectively prove they provide high-quality care to gain any leverage with insurance companies. And this is where clinical infrastructure meets business leverage, specifically through tracking HEDIS measures from day one.
Okay, let's contextualize HEDIS, because that sounds like some serious bureaucratic alphabet soup. HEDIS stands for the Health Plan Employer Data and Information Set. It is governed by the NCQA, the National Committee on Quality Assurance. But what does it actually do on a practical level?
HEDIS is basically the standardized grading rubric for American healthcare. It is exactly how insurance plans measure the performance of their providers. And importantly, it doesn't measure bedside manner. It measures specific, data-driven clinical outcomes.
Right, so things like, did every pediatric patient in your practice receive their full panel of childhood immunizations by age 2? Did every older patient get a flu shot?
Exactly.
Or if a patient suffered a heart attack, was a beta blocker prescribed upon discharge and actually maintained?
Yes. If an NP sets up their EHR to meticulously track and report these metrics from day one, they are generating hard, actuarial data that proves their clinical excellence. This isn't just about professional pride.
It's about money.
It is 100% about money. When it comes time to negotiate reimbursement rates with a massive insurance conglomerate, the provider with a 95% HEDIS compliance rate has tremendous leverage to demand higher pay because they are mathematically proving that they keep patients healthy and out of extremely expensive hospital beds.
Oh, that makes sense.
Yeah.
Because a hospital stay costs the insurance company a fortune.
Exactly. Furthermore, federal programs like Medicare's Merit-Based Incentive Payment System, or MIPS, tie actual financial bonuses directly to these quality metrics. So you track it or you lose money.
Wow. Okay, so we have the location, the software, and the data strategy locked in. But we really have to talk about the actual legal shell of the business, the legal protection. Because if a patient slips on an icy sidewalk outside the clinic, or worse, if there's a medical error like the NP misinterprets a lab result and a patient is harmed, how does the NP protect their personal life savings? Assuming you, the listener, are generally familiar with basic corporate structures, let's focus specifically on how these structures operate in a medical context, because the rules totally change when you are a licensed professional.
They really do, and this is a crucial distinction that trips up a lot of new medical entrepreneurs. Let's look at the LLC, the limited liability company. It's essentially the gold standard for small businesses because it provides a corporate veil. It separates your personal assets, your house, your personal bank account, from the business's liabilities, while allowing the profits to pass through directly to your personal tax return without facing double taxation.
So just to clarify, if you break a 5-year commercial lease, the landlord can sue the LLC for its assets, but they can't take your house.
Precisely. That is a general business liability.
Eh?
But here is the massive, massive caveat for healthcare providers. A corporate veil, whether it's an LLC or a professional corporation, a PC, does absolutely nothing to shield a provider from personal liability for professional medical malpractice.
Wait, really? I want to make sure I understand the mechanics of that. Why doesn't the LLC protect you from a medical error? Isn't that the whole point of a corporation?
You'd think so, but no, because medical malpractice is considered a personal tort. When you examine a patient, you are acting under your personal individual state nursing license, not a corporate charter. The duty of care is owed by you, the individual clinician, to the patient. So if you breach that standard of care, the liability attaches to you personally. The LLC simply cannot absorb a clinical error.
That is fascinating. So the LLC protects you from the business of running a clinic, like slip and falls in the waiting room, vendor disputes, employee lawsuits, but it provides zero armor against the actual practice of medicine.
Exactly, which is why maintaining maximum medical malpractice insurance is totally non-negotiable, regardless of how robust your corporate legal structure is.
Right, because that's your only real shield, which perfectly transitions us into the single most treacherous legal hazard an NP faces. You have your LLC, you have your malpractice insurance, but now you have to deal with that regulatory mandate we mentioned earlier, the collaborating physician. And this mandate acts as basically a trapdoor directly into the most heavily audited area of business law, the IRS regulations regarding employment.
Yes. This intersection of medical regulation and tax law is extraordinarily dangerous. In states that require a collaborative agreement, the NP must find an MD, negotiate a fee, and seal it with a written professional services contract.
And practically speaking, this is a massive vulnerability, isn't it? The NP's entire business is held hostage by this signature. If the collaborating MD decides they want to double their fee overnight, or if they just want to retire and move to Florida, the NP cannot legally see patients the next day. The clinic just dies overnight.
Which is why the structure of that contract is absolutely vital. It must include a mandatory notice period, typically a 60-day or 90-day out clause, before either party can terminate the agreement. This buys the NP the critical time they need to scour the market and secure a new collaborating physician before their legal authority to practice just evaporates.
Right, you need that buffer zone. But the act of hiring that physician is where the IRS gets involved, right?
Oh, heavily.
Let's look at the specific example from the source, the scenario of NP Jones and Dr. Smith, because it illustrates this perfectly. NB Jones is this entrepreneurial nurse who leaves a hospital system, opens his own independent clinic, and needs a collaborator. Dr. Smith, an established physician, agrees to provide the collaborative oversight. Dr. Smith says, "I will physically come to your clinic one afternoon a week to review charts and consult on complex cases, and you will pay me a percentage of your collected revenue."
It is a very, very common arrangement, and it's fascinating because it completely reverses the traditional hierarchy.
Yeah, the nurse is now the boss, and the doctor is the hired help. It's a total role reversal.
Exactly. But how NP Jones legally classifies Dr. Smith on the payroll is a decision that could literally bankrupt the clinic.
Because employees are a massive financial burden. If Dr. Smith is classified as an employee, NP Jones has all these employer responsibilities. He has to withhold federal and state income taxes, verify citizenship, pay half of his Medicare and Social Security taxes, pay unemployment insurance premiums, ADA compliance, OSHA rules, and crucially pay for workers' compensation insurance.
Right. It adds roughly 20% to 30% on top of the base pay.
So naturally, NP Jones wants to avoid all that. He wants to classify Dr. Smith as an independent contractor to save on taxes and just hand him a 1099 form at the end of the year. Can he just do that?
No, absolutely not. And this is where the IRS is just ruthless. You cannot simply write independent contractor at the top of a document and expect the federal government to respect it.
But they signed a contract.
The IRS does not care what the contract says at the top. They use a very specific test based on behavioral control, financial control, and the type of relationship. And in this scenario, Dr. Smith completely fails the test. He is absolutely an employee.
Let's break down the mechanics of that IRS test.
Right.
Why would the IRS look at that and say he's an employee?
Look at the behavioral control. NT Jones dictates the schedule Dr. Smith must be there on a specific afternoon. NP Jones dictates the location. Furthermore, look at the financial control. NP Jones provides all the tools and infrastructure. Dr. Smith is using NP Jones's exam tables, NP Jones's EHR software, and NP Jones's medical assistance.
Ah.
Finally, NP Jones bears the overarching financial risk of the enterprise. Because NP Jones controls the means and methods of the work, Dr. Smith is an employee in the eyes of the IRS.
Wow. Okay, so what is the real-world consequence of misclassifying him? Let's play out the doomsday scenario. Let's say NP Jones ignores the rule, calls him a contractor, and therefore doesn't buy workers' compensation insurance for him. What happens if Dr. Smith is in the clinic, accidentally drops a scalpel, and suffers a severe needle stick injury?
That is exactly the doomsday scenario. Dr. Smith will require medical treatment, post-exposure prophylaxis, and potentially months of lost wages if he contracts a bloodborne pathogen. So, he will file a claim with the State Workers' Compensation Commission.
Okay.
The commission will investigate, they will apply that IRS control test, and they will rule that Dr. Smith was, in fact, an employee. Because NP Jones illegally failed to carry workers' comp insurance for his employee, NP Jones is now personally liable, often completely bypassing that LLC protection to pay Dr. Smith's medical bills and lost wages out of his own pocket. It is a catastrophic business-ending liability.
That is a terrifying trap, just massive IRS fines and personal liability. So how do you legally structure this so the physician actually qualifies as an independent contractor?
You have to completely relinquish control. The physician must operate as a distinct, independent business entity. Practically speaking, this means Dr. Smith should probably never physically step foot in NP Jones's clinic.
Wait, really?
Yes. The collaboration should be done remotely. Dr. Smith should use his own equipment in his own office. He should not be paid a flat weekly salary or a flat percentage. He should periodically submit an invoice on his own professional letterhead, billing an hourly rate for varying amounts of time spent reviewing charts.
Oh, I see.
The relationship must look like two completely separate businesses engaging in a transaction, not a boss dictating a schedule to a subordinate.
That is such a vital nuance. It's all about the illusion, well, the reality of control.
Right.
So, okay, you've structured the legal shell. You've navigated the IRS tax code without stepping on a landmine, and you have your remote collaborating physician locked into a tight 60-day-out contract. The clinic is legally open. Now you face the final, ultimate boss of the healthcare industry, getting paid.
Yes, because revenue in healthcare does not operate like a normal business. In retail, a customer gives you money and you give them a product. In healthcare, the transaction is heavily mediated by third parties. You have 5 main sources of revenue: government programs like Medicare and Medicaid, self-pay, specific contracts, grants, and the big one, private insurers, specifically managed care organizations, or MCOs.
Right, the massive private insurance conglomerates, the HMOs.
Yeah.
And this is where we run into a phenomenon that I honestly found absolutely enraging to read about, the ghost provider problem. I want to use an analogy here to explain the mechanics of this because it feels a lot like the music industry to me.
Okay, let's hear it.
Imagine you are a brilliant ghostwriter. You write a massive hit song, you compose the melody, you do all the heavy lifting in the studio, but the record label refuses to put your name on the track. They credit a famous pop star instead. The song goes to #1, it makes millions, but because your name isn't on the copyright, you have zero data to prove you wrote a hit. When you go to negotiate a contract for your next song, you have no leverage. To the industry, you were a ghost.
That is a remarkably accurate parallel to how MCOs treat NPs in many markets. When an NT applies to an MCO to be recognized as a primary care provider, a PCP, or a medical home, the MCO often just rejects the application outright. They mandate that a physician must be listed as the PCP of record for every single patient.
So let's trace that. The NP examines the patient, diagnoses the hypertension, prescribes the medication, and does literally all the clinical work.
Yeah.
But when the billing claim is actually submitted to the insurance company, it is billed under the collaborating physician's name.
Under their National Provider Identifier number, yes. To the MCO's database, it records that the physician treated the patient. The NP's labor is entirely invisible to the payer.
What is the downstream economic impact of being a ghost provider like that?
It permanently cripples the NP's ability to operate an independent business. Think about it. If you are invisible to the MCO, you cannot prove your HEDIS quality metrics. You cannot prove your cost effectiveness. You cannot prove you have a large, loyal patient panel. Therefore, you have absolutely zero leverage to ever negotiate better reimbursement rates. You are economically tethered to the physician whose name is on the claim, totally trapped in a subservient role.
And it damages the patient relationship, too. I mean, when the patient gets their insurance card in the mail or their explanation of benefits, it lists some random physician they have literally never met as their primary care provider,
Well,
while the NP who actually manages their health isn't even mentioned. It subtly signals to the patient that the NP is just a helper, not the real captain of the ship. It undermines the entire premise of the independent clinic.
Exactly. Which is why breaking out of ghost status and fighting for formal PCP credentialing is probably the most important battle an NP will fight. They have to persuade both the collaborating physicians and the MCO executives to change the rules.
And how do they do that? Like, how does an NP convince these massive insurance conglomerates to let them on the panel as a recognized PCP? The persuasion strategy here is fascinating because it relies on aligning incentives. How do you convince an MD to let you bill under your own name? You play to their self-interest, time, and liability.
That's the playbook. If the MD is the official PCP on record for the NP's patients, that MD is legally and contractually obligated to review those charts and sign off on every referral the NP makes. It is a massive administrative drain on the physician's time.
Right.
Furthermore, it exposes the MD to vicarious liability. If the NP makes a medical error, the MCO and the trial lawyers will immediately look at who the PCP of record is. By allowing the MP to be the credentialed PCP, the physician immediately offloads hours of unpaid paperwork and sheds a massive amount of malpractice risk.
Wow. So you just show them the liability and they hand it over.
Yeah.
But the MCOs are a much tougher crowd. They are massive, slow-moving bureaucracies. How do you convince an insurance executive to open their highly restricted provider panels to a nurse practitioner?
You argue volume and acuity. You look at the data for why people actually seek primary care. The vast majority of visits are not for rare, complex, multi-system diseases. They are the top 10 visits. Hypertension, acute bronchitis, urinary tract infections, minor depression, routine wellness exams. NPs are rigorously educated and specifically optimized to manage these exact first-level conditions.
So you're basically telling the MCO, listen, you do not need to pay a highly specialized physician to manage a basic urinary tract infection. It is an inefficient allocation of your resources. Let me handle the huge volume of low acuity cases with high patient satisfaction and reserve your expensive physician network for complex diagnostics.
It is a very, very persuasive argument for an MCO, but there is a massive counterintuitive trap hidden in this negotiation that NPs have to avoid. An NP might be tempted to say to the MCO, hey, credential me and I will accept a reimbursement rate that is 20% lower than what you pay the doctors. I will save you money.
Yes. Do not compete on price. Why is that financial suicide?
Because of the structural overhead we discussed earlier, the NP has a roughly similar baseline overhead to the physician, plus they have the added unique cost of the mandatory collaborator fee. If the MP voluntarily accepts a discounted reimbursement rate from the insurance company, they are obliterating their own profit margin.
Right. The math doesn't work anymore.
Exactly. They will not generate enough revenue to pay their overhead, pay the collaborator, and take a reasonable salary. They will literally bankrupt their own clinic by trying to be the budget option. They must demand equal pay for equal billing codes.
Okay, so assuming the persuasion works and the MCO sends over a contract offering PCP status and fair rates, the instinct is just to celebrate, sign it immediately, and start seeing patients. But these contracts are total landmines. They are written by corporate lawyers to protect the insurer, not the provider.
An MCO contract is always a biased opening offer. Never assume a contract is non-negotiable. An independent practitioner must scrutinize it, preferably with healthcare counsel, looking for specific predatory clauses. And the two most dangerous ones you'll see are hold harmless clauses and indemnification clauses.
Let's translate those into plain English for the listener. What is the mechanism of a hold harmless clause?
A hold harmless clause essentially strips the provider of their right to collect payment if the MCO fails. It dictates that if the insurance company goes bankrupt or simply denies a valid claim due to an internal technicality, the provider agrees to hold the enrolled patient harmless.
Meaning what?
Meaning the provider is legally forbidden from sending a bill directly to the patient. The MCO defaults, and the provider is forced to eat a 100% loss for the services they already rendered.
That is incredibly predatory. It forces the small business owner to underwrite the financial risk of a multi-billion-dollar insurance corporation.
It's extremely common.
And what about indemnification?
Indemnification is somehow even worse. To indemnify means to compensate for a loss. These clauses often state that if the MCO is sued by a patient because of a decision the MCO made, for instance, if the MCO denies coverage for a life-saving drug that the NP prescribed, and the patient suffers, the NP must indemnify the MCO.
Wait, meaning the MP is forced to pay for the NCO's legal defense and any damages awarded?
Yes. You are signing away your right to defend yourself and agreeing to pay for the insurance company's mistakes. These clauses must be aggressively struck from the contract before signing.
This level of legal and financial maneuvering is exhausting just to talk about, but it's entirely abstract until someone actually executes it. Which brings us to the final phase of our deep dive, making it real. Because we actually have access to a specific granular business plan, a literal blueprint of how an NP takes these abstract concepts to a bank to secure startup capital.
A solid business plan is where theory meets reality. It forces the entrepreneur to stop speaking in generalities and start answering the top 20 questions. Who exactly is the target demographic? What is the localized competitive landscape? What are the unique benefits? How will growth be financed month over month?
To illustrate this, let's dissect the sample business plan provided in the text. It is for a clinic called Main Street Well Women Care, founded by a nurse practitioner named Jane Jones, CRNP, in Bristol, Connecticut. Jane's strategic positioning here is a total masterclass in healthcare entrepreneurship.
It truly is. Her mission is highly targeted. She identified a specific market gap. A local Planned Parenthood clinic recently closed, leaving a vacuum for basic gynecologic services, birth control counseling, and routine infection screenings. She is stepping in to capture that specific abandoned patient population.
But the most brilliant part of Jane's plan is her structural financial model.
Oh, yeah.
She's opening a strictly cash-only business.
Yes.
She accepts cash, debit, and credit cards at the time of service. She will not accept a single insurance plan. She completely sidesteps the entire MCO ghost provider battle we just spent 20 minutes dissecting.
It is a radical but highly effective strategy. By refusing to engage with the insurance bureaucracy entirely, she eliminates massive swaths of administrative overhead. She doesn't need to hire a specialized medical coder. She doesn't need a billing manager to chase denied claims. She doesn't need to spend months fighting for PCP credentialing.
And most importantly, she has zero accounts receivable lag. She gets paid the exact minute the service is rendered, which creates immense cash flow stability for a new business.
Exactly. And because her overhead is so artificially low, it allows her to wield price as a competitive weapon. Her competitive analysis notes that local established physicians in Bristol charge roughly $140 for a routine annual exam. Because Jane has no billing department overhead, she can profitably offer that exact same exam for $85.
Which perfectly aligns with her target demographic. Her research shows that a significant percentage of the local female population, about 40%, is uninsured or underinsured with massive deductibles. To an uninsured patient, the difference between $140 and $85 is literally the difference between getting health care and staying home.
Yeah.
She has created a highly disruptive pricing model.
She really has. And her marketing and real estate strategy is just as sharp. She isn't leasing office space in a prestigious hidden medical park on the edge of town. She is renting a visible storefront directly adjacent to the town's primary grocery store.
Which is brilliant.
It is a highly calculated move based on the mechanics of consumer behavior. The rule of marketing states that a message often needs to be encountered 12 to 27 times before it is learned and acted upon. If you are in a medical park, you have to buy expensive advertising to get those impressions.
But by being next to the grocery store, every woman in that town is going to push a shopping cart past Jane's lit signage twice a week. She is generating thousands of free marketing impressions simply through passive foot traffic. She is normalizing her clinic's presence in their weekly routine, plus flyers, plus word of mouth.
She supplements that with active community engagement. She plans a monthly teen day offering free Q&A sessions for adolescents. This generates zero immediate revenue, but it builds profound brand loyalty and trust. When those teenagers eventually require clinical services or when they talk to their mothers, Main Street Well Women Care is the established, trusted authority.
What really struck me about Jane's business plan, though, is the sheer, unglamorous granularity of the math. When you go to a commercial lender for a $50,000 startup loan, you cannot just sell them a vision of holistic nursing care. Jane has calculated her break-even point down to the decimal.
She knows exactly what she needs.
Right. She knows she needs to average exactly 48 patient visits a week to cover her loan amortization schedule, projecting a payback by December 2025. She has itemized the exact cost of her basic lab supplies. She knows a pregnancy test costs her practice exactly $20, and a microscopic wet mount costs $25.
That level of microaccounting is the only language a bank understands. And it highlights the final, perilous, nitty-gritty checklist of administrative details that an NP must secure or risk sinking the practice. We touched on hazardous waste, but there is an entire web of federal compliance required just to unlock the front door.
Let's run through the mechanics of a few of these because they represent hidden tripwires. For instance, CLIA compliance, the Clinical Laboratory Improvement Amendment.
Yes, even if you are not drawing blood for complex metabolic panels, even if you are just having a patient provide a urine sample to dip a paper test strip for a UTI, you are legally operating a laboratory. You must apply for, pay for, and maintain a CLIA waiver from the federal government, or you are operating illegally and cannot bill for that service.
Or the DEA registration. If you want the authority to write a prescription for anything classified as a controlled substance, you need a federal DEA number, which costs hundreds of dollars, plus a separate state-level controlled substance registration.
And then there is the physical architecture of HIPAA compliance. HIPAA isn't just about computer passwords, it dictates physical space. When Jane leased that storefront, she had to ensure the walls between the exam room and the waiting room were sufficiently soundproofed so a diagnosis couldn't be overheard. She had to ensure the sightlines from the front door didn't allow a delivery driver to see a patient's open chart on a computer monitor.
She even had to draft specific, legally vetted internal policies for things most patients never think about, like chaperones. Will the clinic mandate a chaperone in the room for every single pelvic exam? Will they merely offer one? If they offer one and the patient declines, is there a specific waiver that must be signed to protect the provider from future liability? A lack of a formalized policy in these areas is a massive blind spot that trial lawyers actively look for.
It is a staggering cognitive load. To be a successful NP practice owner, you must simultaneously hold the clinical empathy required to diagnose a complex patient, the ruthless mathematical discipline of an actuary, and the defensive paranoia of a compliance attorney.
Which brings us to a synthesis of everything we've explored today. We have completely dismantled the assumption that opening a medical practice is just about putting a name on a door. It is an act of sustained, multi-front warfare. The NP has to navigate IRS labor laws to avoid personal bankruptcy, fight entrenched insurance monopolies just to be recognized as a legitimate provider, and maintain incredibly tight operational margins.
But if they can survive the regulatory thicket and optimize their operations, they achieve something rare in modern medicine: absolute agency. They have the power to fundamentally reshape how primary care is delivered in their specific community, free from the dictates of corporate hospital administrators.
But I want to close by looking at the macroeconomic reality of what we just discussed, because the math points to a very specific, potentially disruptive future. A provocative thought for you to mull over. We have spent this entire deep dive establishing a core financial truth. An NP can run a highly effective primary care clinic for roughly $150,000 less per year than a traditional doctor, while maintaining strict, data-proven quality metrics.
That is a massive efficiency gap in an industry that consumes nearly 20% of the American GDP.
Exactly, and capitalism abhors an unexploited efficiency gap. So here's the question you have to ask yourself as you look at the future of healthcare. As this NP-led model proves its financial viability, what happens when massive private equity firms, venture capital, or giant tech companies fully lock on to this arbitrage opportunity?
It is the inevitable next phase of market consolidation.
Will the independent, fierce, nurse-owned storefront clinic, like Jane Jones's cash-only oasis, become the new standard of American healthcare? Or will Wall Street simply swoop in, buy up these models, franchise them into thousands of standardized, cheaper NP-led clinics, and turn these entrepreneurial nurses right back into exhausted employees of an even bigger, more relentless corporate machine?
It is the ultimate paradox of their success. By proving they can do it cheaper and just as well, they make themselves the perfect target for corporate acquisition. The autonomy they fought so hard to build might be the exact thing the market tries to buy from them.
It is a chilling but deeply realistic thought. The math is undeniable, and the market always follows the math. Will the name on the door belong to the nurse who built the practice or to a holding company in New York? It is absolutely something to keep a close eye on the next time you walk into a neighborhood clinic and wonder who is actually steering the ship. Thank you so much for joining us on this deep dive into the source material. Keep learning, keep questioning the structures around you, keep exploring, and we will see you next time.